Thank you so much. It's a real honor for me to be here today on behalf of all of my colleagues at Columbia and New York and everybody at CRF. It's just so nice to be here joined by friends, and I thank everybody for coming out here early in the morning. We know that this is a true hardcore contingent of SOLACI and GI2. I have a topic that's going to cover a few things, but the way I'd like to cover these three separate areas is to think about them as part of how we do modern-day PCI as a whole. I think if we were to look in the past at three specific topics, one is the assessment of coronary lesions, two is how much to treat when we see coronary lesions, and then three, how to treat them, we'll find that we've evolved from the past when we were sort of just looking at non-invasive testing and just the angiogram itself, just looking at culprit lesions to treat, maybe leaving other things alone, and then just using angiogram to treat. We've now evolved in the modern era to want to treat with physiologic assessment of lesions, complete revascularization to make sure that all those lesions that are physiologically important are treated, and then when we treat them, we optimize them by the use of intravascular imaging. So to go through each of these topics somewhat quickly, let's start off first with ischemia-guided or physiology-guided PCI. We certainly believe that this is now the gold standard for how we treat coronary lesions. I don't think you have to do physiology on every lesion. I'll show you a figure that sort of summarizes when I think it ought to be done. But it's important to do because I'll show you two case examples of opposite examples. This is a case of an LAD in a patient that was symptomatic. Doesn't appear to be very much. In the old days, many people would simply say, just leave this alone, medical therapy, but it turns out that the FFR is 0.71, and so this is a lesion causing symptoms and or physiologic significance, and this can successfully be treated to help the patient. Similarly, on the other end, this is an example of a patient that was asymptomatic, came with a positive CT angiogram and has this lesion for which you might say we need to do rotational atherectomy or other techniques, but it turns out he's asymptomatic and the FFR is 0.87. So what I would like to leave you with is the idea that when we look at lesions by angiogram alone, absent the clinical context of what's going on, we may be mistreating patients, and it's important to use physiology to guide our treatment for these patients. This has been shown quite nicely by the FAME investigators. In the FAME trial, what was actually shown is that if you have lesions that are 90% or greater, those are virtually always going to be ischemic. But if you're less than that range, in the 70 to 90% range, or even less than 50% range, you may misclassify the significance of lesions based upon a true test like an FFR. And so that's why it's very important to use physiology when guiding PCI. We know from that randomized trial that a physiology-guided strategy was superior to that using angiogram alone. Not only could you do less procedures and save resources in terms of stent utilization, but also the adverse outcomes such as death, myocardial infarction, and repeat revascularization were lower by the use of FFR. Now, what's also known is that if you leave behind disease like that LAD I showed you that's physiologically significant, there's a greater incidence of adverse events if you were to treat those patients medically. So many people would say if FFR is only useful if you don't want to treat disease, and I hope from that case I showed you, and we have many others like this in our lab, particularly in the LAD distribution, that imaging or physiology guidance can actually improve outcomes. Now, it's also important to make sure you don't only look at the cutoff of 0.8 or 0.75 as when you decide to treat or not to treat. The lower the FFR is, or the more hemodynamically significant the lesion is, the more adverse the outcomes are for patients. And similarly, if the FFR is 0.82 and otherwise, actually that's a lot better than if it were 0.6. So that's important to think about when we're looking at these things. So how do I determine when to do FFR? I'm not saying to do it in every case. The key is to look at what the patient comes in with, the clinical scenario, is there non-invasive testing, and the angiogram, and if all three make sense and they fit together, you don't have to do it. But if there's discrepancies or discordance, or one makes sense and the other one doesn't, that's really when you need to think about doing physiology in the lab. Moving on to the second topic, complete revascularization, which is somewhat tied to this, it's important to recognize that we know as you have worse and worse coronary disease, meaning more severe disease and different and prognostically important distributions, the outcomes are worse. This has been well established. It's not that if you just have coronary disease, all stable disease is the same. As interventionalists, we know that if you have disease in the circumflex or OM2 versus left main, prognosis is vastly different. And what's been shown early on in surgical series is that if you did not revascularize all these territories, if you bypass less, that was associated with an adverse mortality after bypass surgery. There was more angina for patients that had more territories left behind as well. And that's the whole logic behind doing complete revascularization or treating all the vessels that actually would merit revascularization as a whole. Now, you can look at this in various ways. You can look at it just based upon looking at the angiogram alone. And if you say that completely revascularizing a patient is when you have all lesions greater than 50% treated, that's one way of doing it. But what we've now started to do is use physiology and FFR to try to determine whether or not lesions are significant and therefore need to be bypassed. Now, we and others have shown that if you leave behind disease within a PCI patient population, that those patients who have more disease left behind, particularly if they're chronic total occlusions, in fact, actually do worse in terms of death and myocardial infarction and repeat revascularization over time. And similarly, medical therapy does not really help in these cases. This was a nice study run by Guro Weiss and our colleagues at CRF showing that ranolazine as an antianginal did not really help symptoms or outcomes in patients that were incompletely revascularized. Finally, it's interesting to note that in at least observational analyses, if we do PCI with complete revascularization, we can actually achieve outcomes that are similar to bypass surgery even in multivessel disease patients. This remains to be shown in a prospective way, but this is intriguing, suggesting that maybe the differences between bypass surgery and PCI relate to the fact that we're not revascularizing everything that we should be or could, and if we were to do that, we could get similar outcomes. How do we determine whether we've completely revascularized or not? Philippe Genereux and colleagues at CRF developed something called a residual syntax score, and that is looking at the syntax score before you treat and after you treat, and whatever you're left with is your residual score. And so in this case, where there's right coronary disease and LAD disease, if you stent the mid-right, stent the LAD, but leave behind the diagonal and this bifurcating to the PDA lesion, you have a residual score of 6. And at least in analyses that were done in our core lab, the higher the residual syntax score, the more disease that was left behind, the worse the outcome, looking at death specifically in this case, for these types of patients. And so that's one of the reasons why we believe that complete revascularization is the way to go. Now, the final aspect of this is whether you can use FFR, not just the angiogram, to help yourself. And this study and others have shown that you can reclassify patients by using FFR to determine what you've left behind is significant or not. So in terms of conclusions and completeness of revascularization, I think that the ability to perform complete revascularization of ischemic and viable territories actually should influence how we determine what can be treated with either surgery or PCI. If you feel like you can do everything with PCI, that might be a reasonable strategy, but if you can't, then those are patients who would merit surgery. It's not just based upon, is this easy to fix or not? Do I have the skills and the ability to be able to treat it safely? Moving on to the last topic, which was imaging. I'm not going to spend too much time talking about it other than to say that imaging in many ways can improve your stenting outcomes, not just post-optimization, but also assessing the vessel up front, determining the size, how much disease there is, do you need to use atherectomy, and then post-intervention maximizing the stent results. I know Alex, Andrea, and many other people have contributed a lot to this field, and it's really important not to leave it only in the niche of those people who are familiar with it, but to expand this more broadly to the interventional community. This was actually done in the ADAPT DES study. This was a study where there was an imaging sub-study, and interestingly, although the catheters were free, many operators found, at least in 3/4 of cases, that they changed what they did. Most often they used larger balloon sizes, they optimized stent results, and basically they were able to change the procedure just by having these imaging catheters being given. And this was not associated with adverse consequences in this study. Now, I'm just going to provide this for your reference. I won't go through it in detail, but the idea with stent optimization is to get the largest luminal size that you can safely get, because that'll reduce not only acute complications, but late events such as restenosis as well. There are now 2 randomized trials in the last year looking at the use of intravascular ultrasound in the setting of complex coronary disease. One was actually in CTOs, the second was in long lesions. This was published in JAMA, basically showing in a randomized way that the use of imaging for complex disease was associated with improved outcomes. There are a small number of events in these studies, but this is the first randomized evidence in a larger series of patients showing that we can improve outcomes with the use of imaging. The final area that imaging is very important is in stent failure. So if you have a restenosis of a current generation drug-eluting stent, you want to know why that's happening. And we can see in some cases it's due to neointima, which would benefit from the placement of another stent. And in other cases, which we see more frequently these days, is under expansion. And putting another stent in these types of patients does not help. It would actually further hurt the patient because there's not enough room for the first stent, let alone the second. So therefore, we kind of feel that if you have a stent failure, absolutely that's one area where you have to use imaging. And that's because current stents or PCI is safer than ever. If we fail, we need to know why, for not only our own sake, but for the patient's sake, and we're going to treat it differently. So just in conclusion, I guess what I started off by saying that we started off in an era of PCI where we were simply just relying upon the angiogram, doing non-invasive assessments, and then just treating patients based on angiography. I think we've now evolved to a modern day of PCI where we're relying not only on the non-invasive and clinical assessments, but also physiology in the cath lab. We're trying to completely revascularize patients with novel techniques of dealing with complex disease. And when we treat those complex patients and lesions, we need to do it with imaging guidance to really maximize our benefits. Thanks so much.